terms of bifurcations, approximately around 35 to 40% of patients who need intervention involve bifurcations. But whether the bifurcation are significant or not, depending on side branch vessel size, that determines the lesion characteristics. And also in terms of your bifurcation, in terms of Medina classification becomes important. So approximately around 25 to 30% have two bifurcations. Those who actually need intervention probably will be around 15% or so. And whether it's a two-stent strategy or a stent and balloon strategy depends on the clinical patient scenario and the size of the vessel, angulation, etc. So I would say roughly who truly need intervention bifurcation probably is, in terms of two stents, probably is around 5 to 10%, not more than that. In terms of strategies for bifurcation, the most common ones that I use is DK crush, QLO and crush techniques. Depends on the clinical anatomy of the patient, how they present, the various size, the angulations, the daughter size, side branch axis, the main vessel axis. All this determines the strategy. But in terms of, I suppose, long-term results, the DK crush is what has shown to be the most beneficial. The second would be QLO, especially if the vessel sizes are almost equal and matching to each other. And the third would be a crush or a mini crush technique. And this is the same order of preference for my cases as well. Now, in terms of side branch axis, the problem can happen in terms of the angulations of the side vessels, and the access to it depends on how many struts are across, getting hardware across. Many times we have an issue in terms of stent expansion at the side branch because of the osteal lesions being tight, in which case we may have to use a cutting balloon or any other accessories that may be required, and finally end with a kissing balloon dilation. Stent required is seen in approximately around probably 5 to 10% in the side branch stent. That specifically happens because of the flow dynamic, just like the ostial circumflex being Achilles heel side branch, especially the diagonal of the OM ostiums do have recoils. That's seen probably around 5 to 10% as I mentioned. And in terms of the vessel diameter, that depends on the vessel, how big the vessel is and how small the axis is actually. The stent trackability and flexibility is extremely important when you do bifurcation. So you should know good knowledge about the hardware, the different types of stents, its trackability and the strut thickness, etc. This becomes more important when you do side branch stenting after the main vessel stenting, because that has to go through a main stent through the struts into the side branch. If you are doing an upfront side branch strategy, it may not matter so much, but this is more so important in a secondary side branch stent strategy. Side branch depends on the main stent features. So a good perimeter area, around 6 to 8 connector, an open cell design is what I would prefer, because that also helps in further expansion of the main stent and the easier access to the side branch. And even sometimes when you're not stenting the side branch, the flow to the side branch remains perfect in this particular main stent scenario. Dedicated side branch stents, I think one particular stent company did have a side branch stent which was being used, but that is only in certain scenarios that has been found to be useful. There is a scope for it. Certainly for people who are not used to doing bifurcation, it makes the job a little more easier in terms of side branch access. But it's not mandatory, but it certainly will help the operator in decreasing the procedure time. Success in side branch intervention depends immediate success and long-term success. So immediate success is purely based on your pinching and TB flow. Also, if the main vessel, the side branch is quite big and you feel there's a significant pinching, there is a role for doing an FFR through the main struts into the side branch and assessing whether it's significant, and then intervene on it if it's required. Long-term depends on the clinical symptom of the patient, and also in terms of further imaging also can be done as a follow-up. Optimal side branch expansion is quite important. As I mentioned, that this is a very important aspect of restenosis. If you don't have a very good minimal lumen area in the side branch, that forms a real chance of restenosis, and each time you intervene on that, there's a chance that the plaque will further shift to the main stent, thus jeopardizing the whole scenario. Even in the acute phase, you have a side branch which is going for a thrombosis, there's a possibility the thrombus will come into the main vessel also. So achieving a very good lumen area in the side branch is extremely important. As mentioned earlier, a side branch dedicated stent is certainly something which can be considered in the future, provided the design and the connection, everything is planned perfectly. As I mentioned, this will certainly help decreasing the follow time and the procedure. Yeah, in clinical data, in terms of, again, you can divide into acute procedure and long-term follow-up. During the acute procedure, a good optimal lumen gain of the area based on imaging, and in the long-term follow-up, symptoms should be free of symptoms, and also the follow-up, the patient should have a good luminal area, especially if it can be proven by imaging. I would suggest a study probably around 500 patients or something, a pilot study or a final study which can be done with this particular new design stent, and if that shows to be good in the long term, at least over a period of a year, then that can be implemented.